So let's talk a little bit about MicroPulse. What exactly is it? It is a, it's a continuous wave pulse, but it's chopped into very small little micropulses with a small shutter that makes sure that you don't get one continuous burn. Because of that, you get a lower energy per pulse, and then it allows for tissue cooling between the pulses, as you can see on the graph on the right. So with a 15% duty cycle, you do get a slight increase in the temperature of the retina, but with a low duty cycle of 5%, you do allow that retina to cool down between each pulse. Now, if you try and just decrease the power of continuous wave, that is actually not equivalent to a micropulse therapy. You do get less tissue heating than just turning down the power. So a few things I wanted to talk with everyone today. I do believe that there is a learning curve with MicroPulse. So when I was first starting using this technology, what I did is I actually gathered my first 100 eyes that I treated with diabetic macular edema and the use of MicroPulse technology. So we found in the total study group of those 100 eyes, there was a statistically significant improvement in the central foveal thickness. But this is what was interesting. What I did was I actually broke up the first half of the eyes versus the second half of the eyes. And I found that the second half actually had much better results. And I think a lot of that does have to do with comfort and technique. And we'll talk a little bit about that as well. Also, something I found in my sub-analysis was that pigmentation seemed to matter. So patients who were listed as Caucasian in our electronic medical records had less of an improvement than patients who are listed as non-Caucasian. And I do think that's probably secondary to the next slide. We used 532 nanometer laser. So 532 nanometer laser is a very widely used laser. The early reports looked at 810 nanometer laser or red infrared laser. And they found that they had most of the absorption at the RPE and very minimal absorption of luteal pigment medial opacity. In fact, can get through vitreous hemorrhage quite well. The power that you need to use, especially if you're going to use it for continuous wave, though, was quite high. And so sometimes can be a little uncomfortable for patients. And so again, we chose 532 in our previous practice. 577, though, really is gaining a lot of popularity. The maximal absorption here is at melanin oxyhemoglobin, and with very minimal absorption of xanthophyll. The power is kind of in between 532 and 810. One great thing about the 577 is really you notice the spots really don't expand after you place them, unlike 532, which can over time. Now with 532 laser, again, it's quite safe even for foveal absorption, but I do find that 532 does have some absorption of melanin. And that's why I do find that I think 532 perhaps has some changes with pigmented eyes, which is why I do a titration spot for my 532 patients. So that brings me to my preferred settings. In my current practice, we use an IQ 532 that has Texcel or pattern laser capability. I use a 200 micron spot size at 200 millisecond duration. I don't change any other parameter other than the power. And I feel that that's because you don't want to change the fluency calculations at all. Because again, when I'm titrating, I do want to try and be as accurate as possible. So I take that spot and I titrate it at a continuous wave burn outside the area of edema. Then I multiply what is a standard focal burn, so my normal sort of gray burn, by 3. And I only go to a maximum of 400 milliwatts. I always do 5% duty cycle. I never go more than that. That is extremely important. In fact, when I used to have a scribe, I would have them tell me what my duty cycle was before I would start the treatment. Currently, I do utilize the ease of a Texcel pattern grid to speed up my treatments. I do a 7x7 grid with 0 spacing. And the reason is you do want a highly confluent treatment pattern. So I'd like to go further and talk a little bit about some of my cases that I've done. So the first is, it was a 73-year-old Asian gentleman who presented to me in 2019 with a diagnosis of polypoidal choroidal vasculopathy. His vision was as listed, and he had been treated Q4 weeks with aflibercept by a retiring retina specialist in another practice. This was his presenting OCT with kind of low-level exudation. This is his first scan. After treatment with me, he presented actually in June, and I decided to continue his same Q4 week aflibercept dosing. And you can see it did improve, but there's still some persistent PED, and the patient remained with metamorphopsia. So we had the advent of brolucizumab around this time, and I was excited about using that for polypoidal. And actually, the patient had a wonderful result after 4 brolucizumabs. You can see nearly flattened PED at this point, and the patient was extremely excited, felt that he was able to read a newspaper for the first time. But then we started seeing the issues with intraocular inflammation. So I switched him away from brolucizumab and went back to aflibercept. And you can see within a month, he had a dramatic recurrence of his PED as well as associated subretinal fluid. So at this point, I decided to try MicroPulse because he was very disappointed with Q4 week Eylea or aflibercept. And so I decided to see what I could do with another modality. These were his photos. I do think it's very important when you are treating any patient with MicroPulse to see what the vascularity looks like. If you look at his PED from his OCT or his infrared image, you might not actually see the areas of leakage. And so you do want to make sure that you're covering the entire area instead of what just looks like the PED on your scan. So you can see after one treatment, he actually did have a significant improvement. And what I would like to stress here is this is not a one and done. This is the goal was to sort of reduce his treatment burden. So he did have a slight recurrence early in 2021. So I did repeat his aflibercept, but he had an incredible result. And so you can see this is here most recently in August of this year. I just saw him a few weeks ago. And so since October 2020 till now, he's had 1 retreatment of Eylea. So again, a very, very excited patient with a single MicroPulse therapy. This was another woman of mine who's 56 and was a professional at a corporation that was actually an hour and a half away from my office. She developed a BRVO with macular edema back in 2014 with very significant vision loss and a very significant central foveal thickness. With regular treatment, she actually did quite well with a vision of 20/30, and you can see a very dry retina. But she started to develop tachyphylaxis of aflibercept and started losing, started actually getting edema even at a 4-week interval, and her vision actually started dropping to 20/60. She also told me I have a lot of difficulty making it to these appointments. I have to take off work every time, and it's a 3-hour trip because she was driving an hour and a half each way. Is there another option for me? So at this point, we talked about MicroPulse therapy, again with an IQ 532 laser. This is 1 month after her laser. This was the vertical raster, and she already had a significant improvement in her fluid. This is now a year after. Her vision continues to improve, and her fluid actually arguably looks better now. I'm now just following her every 4 months. This is now 6 years from her initial treatment, and she obviously could not be happier. So she went from someone who's getting treated every 4 weeks on Eylea to really not needing a further injection. Now, again, all results are not equal. Patients are not created the same. So here are some of the considerations that I've thought of through the years. So when we think about treatment burden, every single patient has a treatment burden. That's the way that I approach this. It is not easy to come in and have a needle put in your eye. It works great, but it is a burden. I definitely find that this is great for patients who are younger, who are working, while live a lot of difficulty making it in. I do think phakic eyes are easier. For some reason, I think that the actual treatment seems to be more and more consistent when I do it through that, and I'm not fighting through any of the lens capsular issues. And social considerations are very important. Again, we are battling through the COVID era, and we're having a second very significant wave right now. So being able to keep these patients, especially immunocompromised patients, out of our office is an extremely important consideration. One thing that I've also tended to notice is I find that patients who are very responsive to pharmacology, that actually do well, that just have a lot of variability, meaning that big sort of accordion effect, seem to be the ones that do better. I find that the ones where they're barely moving and I just try micropulse as some other option don't really seem to be that beneficial. But it's not necessarily that the micropulse isn't working. It's probably nothing's going to work for those patients. So I definitely want us to sort of expand the way that we think about micropulse therapy for some patients who may need it. So thank you very much for your time.